Now this is the time to welcome all our delegates from all over the world and the faculty who have really showed enthusiastic response in to this webinar fifth series. I have a great uh, pleasure introducing myself. I am Dr. T.H. Chandrasekhar, American College of Gastroenterology Governor for the India region. And I bring warm greetings from ACG as the member webinar subcommittee, same time as the member scientific committee from the World Gastroenterology and Tamil Nadu Medical University as his honorary distinct professor. And this whole program is done by Med India Hospital. Warm greetings from our institution. The first four series of webinars saw the participation of over 19,000 plus delegates from all over the world. That really inspired as we started during COVID time. Then we thought we'll stop that level. Then we found that so much of enthusiasm and attendance from all over the world. This is the best platform, I thought so. So we have gone into the fifth series now. The fifth series that come with the tagline, name the topic, the world experts are here. And there's a news here, new Endo-GE webinar series. And this series of webinars have been inaugurated by Professor Dr. Jonathan Lighton, the president of American College of Gastroenterology. That time we scheduled from April 24 to March 25, 12 webinars. Now from April 25 to March 26, again the another series. Now we started again from April 26 to March 27. And one of the webinars are the participation by Professor Dr. Barry Marshall, Nobel Prize winner, and the discoverer of Helicobacter pylori. Then suddenly the webinar sought into fame and more attendance was seen. That particular webinar, we saw the attendance over 10,000 delegates from all over the world. He talked on the journey of discovery of Helicobacter pylori and further. And since then, he has been associated with the various Indian centers to promote the research in clinical and basic research related to H. pylori. And these webinars have been possible with a good coordination and cooperation from my colleague, Dr. Gokul, Satya, Yogesh, and Dr. Prasad, and Tringana Sambandam. And these international webinars have been possible because of the attendance by the national faculty, international faculty. They were readily agreeing to be part of this webinar, and that is the success of this story. And other the medium level consultant where, the mid-level consultant where they're delighted to be as moderator and panelist. It's very difficult to name one after another. And what we have designed is this webinar from April 26 to October 26. We started with a neuroendocrine tumor. Now, GIST also. This time, selection and optimization before liver transplantation and post-liver transplant care physician perspective. The next June 24 will be diarrhea and immunocompromised host and irritable bowel syndrome, art and science of management. And after that, in July, we are going to talk about how did I arrive at the MEL score, the journey and impact and clinics in alcohol-related liver diseases by Dr. Patrick Kamath, who himself the discoverer of MEL score. Following that, in August, we are going to have ulcerative colitis and Crohn's disease management, the current scenarios, and the next two interesting topics will be dysbiosis and GI diseases by Dr. Nageshwar Reddy, and antibiotics, the very difficult topic, Dr. B.S. Ramakrishna, and acute pancreatitis and chronic pancreatitis, natural history and complication management by Dr. Vivek Sandhi from USC and Dr. Surinder Rana from Chandigarh. So, and all these webinars, they get the credit hours of 1 hour from the Tamil Nadu the Tamil Nadu Medical Council. So, you care for the certificate to want a claim for this, the credit hours. So, this time, the topic is very, very attractive and it is very essential for day-to-day care for all gastroenterologists and some of the senior physicians who care for liver diseases and post-transplant. So what do you do before transplant? What do you do after transplant? This is what it is we want to learn from our transplant hepatology. That become a new, unique, and a very important branch of gastroenterology because they are dedicating themselves. So we have chosen the good panelists and the speakers, Dr. Joy Verghese and LVK, L. Venkatakrishnan and Kausal Madan and Dinesh Jojimani. It's my present duty to introduce the faculty. Dr. Joy Verghese, he is student of our unit also. After his graduation, he worked here. I'm very proud to tell that he has really evolved as a transplant hepatologist. We are very happy with the progress he has made. He is the director of hepatology and transplant hepatology clinical Global Health City, Chennai, and managed over 2,000 plus liver transplant surgery. I don't know about now, including 400 pediatric cases. The pioneered therapeutic plasma exchange for liver condition and hepatitis B related transplants in India. And he has been honored with the ISG Om Prakash, a young investigator award by the ISG for research contribution. And he has got several publications to his credit. Welcome, Dr. Joy. And this topic will be moderated by another student of ours and a very good friend and very good clinician and a great gastroenterologist is Dr. L. Venkatakrishnan, Professor Head, Department of Gastroenterology, PhD, Institute of Medical Sciences and Research, Coimbatore. His focused area, apart from liver transplant, inflammatory bowel disease and liver diseases, and he is currently studying on oxidative stress and biomarkers. He has got several publications to his credit. Welcome, Dr. LVK. A good friend from New Delhi, Dr. Kaushal Madan, who also dedicated himself for the transplant hepatologist. He is Dr. Kaushal Madan. He is the principal director and the head of clinical hepatology Max Super Specialty Hospital, New Delhi. Formerly, he was the assistant professor in hepatology, Institute of Liver and Biliary Sciences, ILBS, famously called, from New Delhi. And his areas of include apart from transplant hepatology, liver cancer, liver cirrhosis. Now you see that I think the most of the delegates who are not the hardcore hepatologists see that how hepatology has evolved into that, and he has also several publications to his credit. And we have a very eminent panelist, Dr. Jodhimani Dinesh is another very brilliant hepatologist, and he's a transplant hepatologist. He has agreed to be the moderator and panelist, and he's the director of hepatology services from Rela Hospital, Chennai. Welcome, Dr. Dinesh and Kaushal and Dr. G.S. Lamba. Another very enthusiastic and very good clinician, Dr. G.S. Lamba. He is the director of Action Institute of Liver Diseases and Digestive Diseases from New Delhi. And I welcome my colleague from Nepal, Dr. Bidan Nidhi, is a senior consultant gastroenterology, Chirayu National Hospital, Kathmandu, Nepal. Now, these webinars would not have been possible or would not have been popular without the contribution from our national ambassador. Each state is being represented by the ambassador, Dr. Chaubal, Praveen Roy, Ramesh, and Srinivas, Praveen Kumar, and Dr. Mahapatra, and so on. And Dr. Lamba is our ambassador for New Delhi and Haryana and every state. Usually, we have very enthusiastic, very active international ambassadors from USA, Malaysia, Nepal, Bangladesh. And this way how we designed our webinar to reach and to audience from all over the world. And we welcome you in the same enthusiasm to our due live workshop going to happen in February 2027, 26, 27, 28. Every year is an annual academic event. So being attended from all over the country and neighboring countries also. With this, I will move on to the most interesting session, the lecture session. I invited Dr. LVK to introduce the topic and invite the speaker and Dr. Gokul also to handle my role. If I'm not able to get an access while traveling. Okay. Now over to you, Dr. LVK. I will stop
Yes, sir.
sharing it.
Thank you for having me here today. I think today we have two interesting sessions, and the first one is the most important thing, which we need to have a pre-operative correct evaluation of a liver transplant so that we have a successful liver transplant. And it is important that it has to be percolated to the physicians, because the patient is waiting during the transplant. We need to take care of these patients very well, and they don't have any interlude illness. And it is also imperative that you do a good pre-operative action, which includes your kidneys, heart, everything before you undergo transplant. And I request my good friend Dr. Joy Verghese to start his lecture on pre-operative evaluation of a liver transplant, what needs to be done in general, and in some points in some patients who may require evaluation other than a routine evaluation. Over to you, Dr. Joy.
So, good evening, sir. So, many thanks for the kind invitation, sir. Actually, am I audible, sir?
Yeah, you're audible, Joy.
So, it's my pleasure.
Slides are visible, okay.
Yeah, it's my real pleasure for your kind invitation, sir. And I'm really happy to be the part of the international webinars on the 5th series and giving the opportunity to talk about selection and optimization before liver transplantation. So this is the flow of my talks going to that. So what is the introduction and the indication, current challenges in liver transplant, when to refer the patient, and the expanding spectrum for liver transplant, pre-liver transplant evaluation and optimization, fertility and outcome of transplant. If you take the liver transplantation, we all know the definite cure for the ALF and the ACLF, as well as decompensated chronic liver disease and some malignancies, particularly the liver malignancies. And we are seeing, even though success rate shows more than 95%, but nowadays the success, that means outcome of liver transplantation, varies from center to center based on the expertise. More than that, patient selection, and that will cause the more and more morbidity and mortality. So what are the influencing factors causing the major challenges in outcome is if the patient have not only one organ failure, if they have a multi-organ failure, if they have the many comorbidities that influencing, and there the social and environmental factors are influencing, and their physical fitness and the psychological reserve. So these are the current days, the challenges to us in each liver transplant center. The basic slides to come to know what are the indication for liver transplantation. Acute liver failure. We all know the definition of acute liver failure and what are the causes for acute liver failure, that means the fulminant hepatic failure. Similarly, if you take the cirrhosis, a decompensated chronic liver disease, the various etiology. Metabolic liver disease, some of the metabolic liver disease will not have decompensation. Even though it doesn't have a decompensation, for the better quality of life, particularly this will happen in the pediatric age. It will not be a cirrhosis, but we will consider liver transplantation. And low MELD, that is the challenges. So earlier we thought whenever the high bilirubin, severe coagulopathy, and these all the major factor for the liver transplant, but nowadays they are giving more and more important to the complications of the decompensated chronic liver disease that will come under the low MELD groups. There are miscellaneous So it is not the liver disease, but at the still, we have to consider liver transplantation for better quality of life. For example, adult polycystic liver disease. So the cystic, because of the cystic lesion, it is a benign, but still for the better quality, not all patients, selected patients, these are miscellaneous. Vascular disease of liver, we all know the Budd-Chiari syndrome. Irrespective of our medical management or interventional technology, but still it is a decompensation we need. And the malignancy, of course. So the current challenges in our liver transplant, again, I'm saying the candidates, earlier days, if you see the literatures of 1980s, one of the absolute contraindication for liver transplant was age more than 60. It has been published in NEJM. But we all know age is not a criteria. And at the same time, the comorbidities. Earlier days, if the patient have, even though HIV infection or morbid obesity that cause the contraindication. Nowadays, even though morbid obesity is there, it is not a contraindication. We can consider the patient. Other challenges we are seeing in liver transplant, whether it is a living donor liver transplant or a cadaver program, so organ shortage and the long waiting period, that time the patients, the quality of their life, and they'll get more and more complication. At one point of time, they'll become unfit, the candidate for liver transplant. So when normally we have to refer the patient for liver transplant, if you see the literatures, simply it can show us the MELD score. So we all know how to calculate the MELD score, just the three parameters, bilirubin, INR, and creatinine is a logarithmic score. If it's more than 15 and more than 15 need liver transplant. Here we have to understand it is a dynamic score. If the patient comes with some sort of acute insult, that particular point, the MELD score will be higher. Once the acute insult goes away, the MELD score will come down. So that's why always we have to carefully calculate the MELD score. And in pediatric age, there is called PELD score. And the 2014 ASLD guidelines wise, this again, the indication here, I wish to pinpoint that the last one, hepatopulmonary syndrome, portopulmonary hypertension. This kind of the patient also, we will not expect the full decompensation of the chronic liver disease. At the same time here, the problem, if you are not addressed on time, when the stage progress, even though hepatopulmonary syndrome, if it goes to the severely, then it will become irreversible even after liver transplant. So there are these stages are there. So we shouldn't choose the patient, okay, by undergoing transplant, it will become completely reversible. Similarly, portopulmonary hypertension. If they have the severe portopulmonary hypertension, liver transplant is contraindicated. So that's why we should approach the case by case, a patient's associated the comorbidity status and the complications of each complication of the decompensated liver disease, we have to look into that. The recently, the ESL guidelines, again, it's insisting age is not criteria to choose. And there are newer scores are upcoming. Initially, when the MELD was implemented, MELD, NA, it came sodium, MELD sodium, delta MELD, and so many were the MELD with ascites, this kind of scoring system came. Nowadays, for women, the MELD 3.0 we can use. And earlier, severe alcoholic hepatitis was not considered for liver transplant. And we have to insist for the abstinence of the 6 months. This all was the recommendation. Now, over the period of time, there is a changes in the choosing the patient. And here we have to consider early liver transplant, isolated neuro-Wilson, initially, in a Wilson disease, in a decompensated chronic liver disease only, they consider liver transplant based on the scoring system. There is a separate scoring system for Wilson disease. But now, even though liver appears normal, there is no chronic liver damage, either imaging wise or LFT wise. Still, we can consider liver transplant for neuro Wilson isolated, because here it's completely reversible. Again, here I am going to tell, if there is a permanent damage, neuro related, there is a deformity, usually if it happen, then it will become we shouldn't consider for liver transplant. Earlier days, pre-existing malignancy, we had to wait for minimum 5 years. Nowadays, that also getting relaxed. And if we are very sure the patient is cured, we are getting the certificate from our medical oncology colleagues, then we can consider. So this indication for liver transplant is keep on expanding. So each expansion wise, we have to think about post-liver transplant management, because that time, if you take a alcoholic hepatitis, there is a chance of, again, there is the alcohol-related injury to the liver. If you take a malignancy, there is a chance to get the recurrence due to the immunosuppressive therapy. So we have to keep all in our mind. MELD score, I told already. And here I wish to insist MELD exceptions. Why I am insisting the MELD exception? Nowadays, in the era of mast cell related chronic liver disease, the transplantations numbers are keep on increasing. Here, we are not seeing patients with the high MELD. Most of the mast cell, earlier called NASL, now the metabolic dysfunction associated liver disease, most of the patients will be on the low MELD because the bilirubin will be less than 2, albumin will be low, but INR will not that much elevated, but patients will come to our clinic again and again for the refractory ascites or refractory hydrothorax, or if they get the umbilical hernia rupture due to the ascites. These kind of the complications, and that will lead to the short-term, their lifespan. So this all will come under the low MELD. So nowadays we are seeing low MELD criteria, MELD exception criteria like refractory ascites, recurrent hepatic encephalopathy, hepatopulmonary syndrome, and portopulmonary hypertension I already mentioned. So we have to assess very carefully and we have to choose. Otherwise, even after liver transplant, the outcome will not be good. And in the intractable pruritus, particularly in the pediatric age groups, that time either the neonatal related cholestasis or sometimes unknown reasons, sometimes there will be a severe cholestatic form, that all, other than the biliary atresia, other than the failed Kasai, sometimes intractable cholestasis. In adult, if you take, sometimes this will come as the secondary, the PSC. That time also we have to think about the liver transplant. The miscellaneous, here I wish to highlight few things. One is the familial amyloid polyneuropathy. The patient LFT imaging will be normal, but they will have the neuro problem, and that disease will progress to the motor, sensory, autonomic nervous system dysfunction. So that all we should consider liver transplant early stage. Similarly, the primary hyperoxaluria, the patient imaging everything will be normal, but due to the primary hyperoxaluria, they will develop the chronic kidney disease, and either the child or adult, they will be on the regular hemodialysis. So that time, by undergoing kidney transplant alone, it will cause the recurrence of the disease. That means the oxalate is secreted from the liver, that will cause the renal failure, and the new graft also will fail. So that particular group of patients need combined liver and kidney transplant. So the liver transplant means not only set with the MELD score, there are variety of the MELD exceptions also we have to consider. So this already I mentioned. Nowadays, MELD NA has been popularly used, but in India, if you take most of the transplants are living donor liver transplant, we are not looking into that scoring system much, I mean the categories. But if you take a Western world, the organ allocation is based on the scoring system. But in India, even the cadaver liver transplant in various states, organ allocation is not based on the scoring system, it is based on the date of registration. In the renal transplant, the organ allocation is based on the date of dialysis. So here, it is not much valuable in our country regarding the scoring system validity, but it will say whether the patient need liver transplant or not. This modified MELD, as already I mentioned about, there are so many different types of MELD score has been derived and followed up, and many papers has been research were published. But overall nowadays, MELD NA and UK MELD for the UK it is nowadays it will be practiced. This MELD score are not applicable in ACLF. Even child score also not applicable. So whenever we are going to see the patients with acute on chronic liver disease, so how I told mast cell related decompensated chronic liver disease, the prevalence are increasing, and we are following the MELD exception criteria in ACLF also increasing, because underlying fatty liver, they will get an insult, either hepatitis A virus or E virus, or underlying cirrhosis, compensated cirrhosis, they will get any toxin, drug induced. So this will cause the ACLF. That time we should follow the either CLIF score or the CLIF with the organ failure score. In APASL's recommendation, ARC score. So this kind of the scoring system advantage, it's all dynamic. Suppose at the time of admission, the patient's values, either the bilirubin, lactate, INR, their conscious level or pH, that will vary over the period of time, even 24 hours, 48 hours. If there is an improvement is there, definitely the score also shows improvement. So same way, organ failure in Western world, one and more than one organ failure. That is a very simple rather than the ARC score. So if the patient have liver failure with renal failure, or respiratory failure, or cardiac failure, or hepatic encephalopathy, so based on the organs we can calculate. One organ failure, 2, 3. So more and more organ failures there, that patient's outcome of transplant will be bad. And the ARC score also, if it's very high, it is not a candidate for liver transplant. So this kind of the scoring system is useful. ALF, this the King's College criteria is still standard for our page to choose the patient for pulmonary hepatic failure. It is exception in rat-all poison. The rat killer or yellow phosphorus poisoning are common poisoning what we are seeing in India, and particularly the southern part of the India. Here we will not use that King's College criteria, because if we apply the King's College criteria, most of the patients will be the indication for liver transplant. So the recently CMC Vellore, one of the center, has published it very well. So here we are not, but at the same time, the patient have the altered sensorium. Then the patient need a liver transplant in the patient. If you fulfilling means altered sensorium and severe coagulopathy, that's more than enough. Most of the poisoning patient nowadays, they are getting not only the liver related, due to the poison effect on renal, or the poison effect on pancreas, or the poison effect on cardiac. So before taking the case for emergency liver transplant, we should rule out associated pancreatitis or associated renal dysfunction or associated myocarditis in the yellow phosphorus poisoning related acute liver failure. And this is the criteria, the apostle wise also and the cliffs wise using, but it's already explained to all of you. Now the liver cancer. In the liver cancer, whenever we are going to suggest for liver transplant, if the background liver is normal parenchyma, we shouldn't use this criteria, either Millen's criteria or UCSF criteria. Both these criteria is applicable for underlying chronic liver disease, either the compensated or decompensated chronic liver disease. In most of the centers in India, they are following the UCSF criteria. So, but in Japan, it's varying, and in China, there's a different scoring system. So in India, most of the centers are following University of California and San Francisco criteria for HCC before to take the case for transplant. Even simply, I have mentioned the criteria here, the tumor marker. Here, the criteria doesn't mention alpha fetoprotein importance, but in practice, if the patient have high AFP, alpha fetoprotein, high AFP means if the alpha fetoprotein value is more than 200, if you are taking the case, okay, this patient is fulfilled the criteria, mean there is more chance of HCC recurrence after liver transplant. So we should apply the criteria. At the same time, we should look into that, the tumor marker value. If the tumor marker value is high, we have to go for downstaging. There are so many downstaging options are available, either interventional radiological techniques or the SBRT. So one of the downstaging technique ways, we have to bring down the tumor marker, then we have to go ahead for liver transplantation. There are the types of liver transplant we all wish to know. Particularly, even though I mentioned so many things, key in our practice is when to do liver transplant, when to do combined liver and kidney transplant. So there is the major challenge nowadays we are seeing. Most of the liver patients, they will get the renal dysfunction. The renal dysfunction, if it is a classically fulfilled acute kidney injury, it will be straightforward. We can say the patient need liver transplant alone. But sometimes the AK will be the recurrent, or sometimes acute kidney injury will be the AKD, acute kidney disease. That time the dilemma will come whether after the liver transplantation, the patient's renal function will improve or not. So that is an important challenges nowadays we are facing. So how to optimize? So another 10 to 15 minutes, I wish to tell about in the following heading, how we can optimize a transplant center to be, this is applicable for, even though the center is not a non-transplant, but in the day-to-day practice, we are facing almost all complications, cirrhosis-related complications like hepatic encephalopathy, acute kidney injury, variceal bleed, and the ascites, etc. So hepatic encephalopathy. So if a patient waiting for liver transplant, so that type of encephalopathy, so we have to, first of all, we have to rule out associated neurological and the psychiatric illness. And particularly here, we have to look into that electrolyte abnormality. The low sodium, not potassium, we all know low potassium will cause hepatic encephalopathy. Nowadays, due to the salt restriction, very strict salt restriction, most of the patient will come and get admission due to encephalopathy due to severe hyponatremia. So we have to do the thorough investigation whenever the patient comes for admission, even though it might be the recurrent admission due to hepatic encephalopathy, each time the precipitating factor will vary. The encephalopathy, this time admission might be low potassium. Next encephalopathy admission might be due to the GI bleed, or next might be due to the large volume, the rapid, the paracentesis, or sometimes it might be the low sodium. So each time whenever the patient gets admission, we need thorough, and the treatment we have to go for empirically, we can use the laxatives, the lactulose enema, and the rifaximin, and these all branched chain amino acid, L-ornithine, L-aspartate, these all nowadays is very, extensively used in the encephalopathy stage, because not only ammonia, even though ammonia level might be normal or low, but still they have the encephalopathy. So that time, all these substrates, so this kind of the supplements might require. Very sick patients sometimes might require, refractory cases might, here in India, they are doing the plasma exchange, the large volume plasma exchange. So extracorporeal albendal is not available, and hemofiltration is useful only for acute liver failure, the encephalopathy, not for the decompensated chronic liver disease or ACLF. And these are again the steps-wise assessment, and we have to underlying disease, and whether the alcohol withdrawal or psychiatric or drug overdose, electrolytes, these all we have to clearly, and the assessment-wise, we have to detailed assessments are important in each admission whenever we are seeing with the hepatic encephalopathy. At one point, if we fail, the patient might require for the mechanical ventilation. Once the decompensated chronic liver disease goes to the ventilator, then the chance of the fitness for the liver transplant is questionable. In acute liver failure, even though patient on ventilator, we can assess the neurologically, and if the patient is fit, we can shift the case to the theater. After liver transplant, the patient will come out, recover very well. But a decompensated chronic liver disease, once goes to the grade 4 hepatic encephalopathy, and if they goes to the mechanical ventilator, even though the FiO2 requirement is 30% or less than 40, but with that, if you are going to do the liver transplant, that time that neurological recovery is questionable. So we have to know when should we do the liver transplant, even though in the stage of complication of the decompensated chronic liver disease. These all the practical, the guidelines which have been recommended for our day-to-day practice. There are but we all the center to center. Sometimes that the medications, the style of management vary, but most of them are the common. And ascites, this is a real challenge nowadays. Not only the volume overload, because of the repeated paracentesis, patient will go to sarcopenia. Totally, they will lose their muscle mass. They will lose muscle mass in the particularly respiratory muscle mass. Finally, they'll become very difficult. They have to depend on the ventilator even after liver transplantation for many, many days. So we should, the refractory ascites management is a key challenge. And how much we have to do, and the large volume paracentesis related complications, either hypotension or the AKI or the site-induced bleeding, because sometimes it will injure the collaterals, subcutaneous collaterals, the bleeding, and sometimes refractory ascites will go to chylous ascites. Usually the fluid will come as a chyle, like thick whitish. So each race, they will start to lose all their protein mass. So we have to know when to do the tapping. We have to know the diuretic related complications, and the overdose sometimes will cause the hypokalemia, the diuretic induced hyponatremia, or sometimes lead on the AKI. So that is the real challenge in the volume ascites, particularly refractory ascites management. And these are the guidelines how to give the diuretic dose and how to monitor the diuretic induced the complications, and how to replace the albumin, what is the dose. And whenever we are going to do the refractory ascites tapping, we should send the ascitic fluid for the cell count to rule out SBP, because SBP is anytime can occur due to the gut organism. It causes a translocation. Even though patient, the classical ways, we can sometimes see the abdomen pain, fever, but sometimes silently we'll go to the SBP, and at that time, if we diagnose SBP, we have to treat the patient with the proper antibiotics with albumin. Otherwise, it will cause the renal dysfunction. Then the outcome of the patients, mostly once they get the kidney injury, most of the patient will recover, but sometimes the recovery will not be, not a normal range, and going for sometimes the patient will lead to the RRT, renal replacement therapy also required. So SBP again, so here again insisting, mostly we should treat the patient with the proper antibiotics. Normally the gram-negative coverage, because that organism will be gram-negative, so gram-negative coverage antibiotic we have to give. And here acute GI bleed alone, so the duration is the 7 days, antibiotics fine, oral therapy also. But here in other cases, either previous episode or the patient who have this kind of the components, so that time we have to give the oral antibiotic for covering the gram-negative organism. So the variceal bleed, this normally we have so many options. Here decompensated chronic liver disease comes with varices, either the esophageal varices or fundal varices, or if they have the ectopic variceal bleed, or sometimes it will have the severe portal hypertension gastropathy related. So endotherapy is the first choice, and the medical management, beta blockers, corvidilol we can use, and still it is the patient, we have the endoscopic option, the variceal bleed again, sprays there, the stents are available. But here sometimes we will not get the good vision while doing endoscopy in active bleed. So if you get a point of the site of bleed, easily we can manage. If there is totally that time, even the patient will be on ventilator, because very difficult to manage the patient, massive GI bleed without ventilator support, do the endotherapy. With ventilator support, even if you look into that, everywhere frank blood will be there. That time we have to take the case. If endotherapy wise we are finding difficulty, means that one of the option, emergency tips. The challenges in emergency tips, again, the expertise and the things and the availability of the things. So if emergency tips is successful, then we can control the bleed very well. Some of the patients we are seeing endotherapy will be successful, but again and again they will come with the GI bleed. So that particular groups only we will consider for liver transplant, but mostly the patient endotherapy non-available countries, suppose emergency wise, suppose some of the countries very difficult to go for emergency endotherapy. That kind of the groups, if comes to us, that time we will suggest better go for liver transplant, because we all know as endotherapy emerging is not available, we will lose the patient just because of the GI bleed. So the liver transplant indication, that also varies based on some of the, variceal bleed in Indian patients, usually no one will recommend for liver transplant. At the same time, some of the countries, the endotherapy are not available emergency. That time we can consider. AKI, this all we are routinely seeing due to the various reasons. This is a real challenge in our day-to-day practice, because the earlier the renal parameter will be normal, but here again the definition has been totally changed. Earlier days, whenever the serum creatinine level If it's more than 1.4, they will consider as the AKI. Nowadays, definition, no. Even though if there is more than 50% rise of the creatinine compared with the previous value. Example, I can say if the 0.5, it is the 1 week ago, now it shows the 0.9, it is called AKI. So the rise in creatinine compared with the previous value, and this is the important slide. So now, earlier days, AKI, CKD, only two terminology was there. Now there is a terminology called AKD. One is the acute kidney injury. That kidney injury should recover within 7 days. If there is no recovery, the creatinine level is very high or is a static or progressively increasing, that time it is called AKD, acute kidney disease. So why they are giving importance to the acute kidney disease? This acute kidney disease, over the period of time, sometimes it will progress to the CKD, chronic kidney disease, the during time period. If they cross more than 3 months, the elevated. There is a chance the acute kidney disease is also revert back to the normal renal function. So the definition here I have mentioned, but if you look into that, this is the practical application in transplant center. It is very important. If you are seeing acute kidney injury, we will say 100% after liver transplant, the patient will not get the renal dysfunction. If the patient have a chronic kidney disease, we will recommend only combined liver and kidney transplantation. If you are going to see the patient with the AKD, that time you will give the warning signal to the family member. The patient's renal parameters are not normal. There is a chance the patient will recover, the renal function will recover after liver transplant, or sometimes even after liver transplant, the renal function, there is a chance to progress to the CKD. So in this all the way, we have to assess, now of course, the nephrologist and so many. So we have to see why the patient in AKD patient is progressing to CKD. What are the precipitating factors there? We have to try to correct it. This way we have to work on it. The AKI, there are so many reasons we all know that causing the AKI. Over the period of time, only the AKI is going to AKD and CKD. But the CKD is a different things, because if the patient have associated diabetic or hypertension or the B or C virus related glomerulonephritis, so many things. So other than that, these are the major things. Here we have to look into that, which are the things we can prevent. Number one, large volume paracentesis, we can prevent. Number two, SBP. So that's why, under contrast, if the patient we are planning.
Dr. Joy?
Yes, sir.
I think we have to wind up in 5 minutes.
Perfect. So I will come to the last one, sir. Actually,
yeah, because okay.
The sarcopenia, that's important in our population. There is a various reason. One is the disease progress or due to the refractory ascites. Lifestyle modification, we have to initiate before the patient goes to the child disease status. That is number one. And the nutrition also, even though child A status, even though not indication for liver transplant, we should insist to both the lifestyle modification, nutrition, and the exercise. If the patient goes to child disease status, very difficult to maintain the lifestyle, and the nutrition also will not be a successful absorb, and the exercise also difficult. This all. And now outcomes, okay. Now to summarize the things, managing the complication of the ESLD, that is the key. If you are managing, then there is a chance to keep the patient until the day of transplant stable. Sometimes we will lose the patient irrespective of all sort of efforts. Ideal time to refer the transplant, child A itself, we have to tell to the patient, now you doesn't require transplant, but if your disease progress, there is a chance to give. So we have to maximum maintain the patient in the child A category. indication and expanding, I already told, scoring system, I told, pre-transplant evaluation and that related each component we have to give important. Outcome of transplant nowadays, very good in both pediatric and adult liver transplant. Almost it goes to more than 95% success, but provided if you are going to take the patient in the ideal setup. Thank you so much for the kind listen, sir.
Thank you, Joy, sir, for the excellent lecture. Over to LBK, sir.
Thank you, Joy. That was a very exhaustive lecture on both what are the complications we expect, when is the transplant is indicated, and most importantly, how do you optimize patients on waiting list, like especially management of ascites and AKI. I think two common things will problem always, three common things which will always problem when the patients are being or on the waiting list is one is infection, then AKI, and sometimes bleed. And some of the patients may come with encephalopathy, but the most common things which we face is an infection and leading on to AKI. So my question is there any particular patients whom you would say that we should do a coronary angio by patients?
LVK, can we have questions at the end of 2 lectures?
Okay. The panelist needs to comment anything, sir? No. Panelists.
Sir, at the end of the second lecture, we will have the discussion.
Okay. Okay.
So,
Then it's
the second talk, actually. So, yeah, the next talk is post-liver transplant care, physician's perspective. This is a very important aspect of transplant, being a transplant hepatologist. So I would like to invite Dr. Kaushal Madan, who is a Principal Director, Head Clinical Hepatology, Max Healthcare, New Delhi, and he's my dear friend. Kaushal, over to you.
Yeah. So good evening, everyone. Thanks to Dr. T.S. Chandrasekhar for inviting me to this wonderful meeting. And I'm really impressed with how the previous meetings have gone. And I'm really proud to be part of this. So thanks once again to ACG and Dr. Chandrasekhar. So I've been asked to speak on post-liver transplant care, physician's perspective. Dinesh, am I audible?
Yes, Kaushal. Yes.
Yeah. So I can go on. So you just heard Dr. Varghese talk about how the liver transplant survival has improved over last 3 to 4 decades. If you look at this particular data from 2017, over these 5-year periods, starting from 1985 to 2003, the survival after transplant has progressively improved. And based on this data, it is upwards of 80% over next 10 to 15 years. But if you look at the data presented by Dr. Varghese, so if you look at the latest data, patients who walk in for transplant, almost 85 to 90% or even more of them are able to survive for a very long time. And that is because of the evolution of immunosuppressive protocols, as well as improvement in post-transplant ICU care in these patients. So the median survival in this study was 22.5 years, but still it was 7 years lower than general population average. So something else was killing these patients. So what are the problems which these patients face in the post-transplant period? So these are those issues, the liver dysfunction, which can happen early and late. Infections, particularly early, you have bacterial and fungal infections, and then there are viral infections followed by tuberculosis. Renal dysfunction is a very important complication which occurs in the post-transplant setting. And then there are further long-term complications like extrahepatic malignancies. And now people have realized that one of the most important things to affect these patients in the post-transplant period who have otherwise stable liver function is metabolic dysfunction associated steatoliver disease. And Joy did talk about that. So what happens in the early post-op period? There is allograft. If there is allograft dysfunction, there is derangement in LFTs. So first you have to rule out vascular infropathologies like blockage of portal vein or portal vein thrombosis or hepatic artery thrombosis. Then you rule out vascular outflow pathologies. And finally, you rule out biliary tract pathologies. You may have a anastomotic leak or anastomotic stricture early on in the post-operative period. And once you have ruled this out, then if the liver dysfunction persists, then it is given a term called early allograft dysfunction or EAD, which has to be differentiated in the early post-op period from rejection as well as sepsis. Now, this particular, although this is a single slide which is showing these three things, this in itself is a talk, and this pertains to management of these patients, especially in the first 2 weeks after transplant, maybe a month after transplant, and which is done in the post-liver transplant ICU. So in terms of when we are talking about physician's perspective, I'll not waste much time here, and I'll move on to other issues. So I told you that liver transplant recipients are at a higher risk of dying more than the general population, even though the survival has improved. So what are those causes of death over long term? Again, this is old data from orthotopic liver transplant setups over a follow-up period of 12.6 years. And you can see the non-hepatic causes predominate 63%, of which predominant problems are infections, cardiovascular problems, malignancies, which are de novo malignancies, and renal failure or CKT. So these are the bulk of issues which are killing these patients. Another large study of two cohort, more than 84,000 UNOS and University of Wisconsin patients, 1,400. The extra mortality in long term, usually after 3 to 5 years, are related to non-hepatic and non-transplant related causes, specifically cardiovascular, de novo malignancy, and infection. And if you look at the risk factors, these include renal failure, diabetes, hyperlipidemia, and obesity. So this is everything which involves the physicians in the management of these patients once they have a stable liver function. This is where we want the physicians to manage these patients and reduce their extra mortality. And you will realize that this is what is the theme of this talk, recurring theme as I move ahead in my talk. So let's talk about post-liver transplant renal failure first. So if you look at this large data of 69,000 non-renal transplants between 1990 and 2000, you can see that 16.5% developed CKD, and liver is among the topmost after intestinal transplant to be the one responsible for renal dysfunction in the post-transplant setup. When you look at all solid organ transplant, liver is among the top after intestine, being responsible for developing renal failure in the post-transplant period in almost 25 to 30% patients. So let's look at what happens in liver transplant. So in liver transplant recipients, this was a large study of 752 patients. They defined CKD as reduction of GFR to less than 60 mils per minute and followed up for at least 7 years or a median of 7 years. And they found that 60% developed CKD, which is a huge number. And these were the risk factor. Again, age, female sex, MELD, de novo metabolic syndrome, and AKI. So again, if you look at this recurring theme, the de novo metabolic syndrome, which develops after post-transplant period, is possibly one of the important risk factors for developing post-transplant CKD, and which the physicians must keep in mind, and I'll come to that later again. And this post-transplant renal failure not only leads to a poor graft survival, it also leads to a poor overall survival of the patient in these patients. And when they looked at what is the main thing which is driving this end-stage renal disease in liver transplant patients, they even did biopsies in these patients, and they found that the most common cause of renal dysfunction in these patients was calcineurin inhibitor induced toxicity. CNI toxicity appeared to be the most common driver because of the use of cyclosporin and tacrolimus as the immunosuppressive agent. Although this is very important in order to prevent rejection, but at the same time is also responsible for post-transplant renal dysfunction. So how can it be prevented? So one way to prevent was to change or add another immunosuppressive agent, which would help us reduce the dose of tacrolimus. So there came this new drug called the everolimus, which was the mammalian target of rapamycin inhibitor or mTOR inhibitor. This was the initial RCT in which standard tacrolimus dose was compared with reduced tacrolimus dose or tacrolimus elimination along with everolimus, and it was seen that patients who received reduced TAC or tacrolimus elimination had a significantly better EGFR maintained over 24 months post-transplant as compared to those in which tacrolimus was continued in a higher dose. Although we are not suggesting TAC elimination, what we now follow is even if we are adding everolimus, we reduce tacrolimus in order to preserve their EGFR. Yes, we have to make do with certain complications which are higher in this particular group, like hyperlipidemia or dyslipidemia, bone marrow suppression, stomatitis, and bacterial infections, which are higher with everolimus. And then came the study, which was a 3-year extension study, which further confirmed that patients who were given everolimus with reduced TAC doses maintained their EGFR even up to 3 years following liver transplant as compared to standard dose tacrolimus. So the physician should monitor renal functions every 6 monthly in these patients, avoid nephrotoxic drugs, which is you might say that's a general advice given to all patients, but it should be done with the same vigor as they do in renal transplant recipients, or sometimes patients who come to us and say, doctor, we only have one kidney, so please be careful with us. You have to be as careful as that even in these patients. You manage risk factors. Again, the same recurring theme: obesity, diabetes, hypertension aggressively, which are risk factors for kidney failure development in these patients, and minimize the dose of tacrolimus in consultation with hepatologist. The second important killer I told you is de novo malignancies. So this is a large study over 3 decades or 2 decades among 3,800 liver transplant recipients who developed more than 4,000 de novo non-skin malignancies. As you can see, although the risk starts rising even in the first, second year, but the maximum risk rises beyond 5 years post-transplant. And if you look at the most common cancers, in males, it is usually lung, followed by liver, prostate, and colorectal cancers. And in female, again, lung, pulmonary carcinoma being the most common, followed by breast. And when they looked at the on multivariate analysis, the independent factors associated with de novo malignancies, again, the same problem. If the transplant was done for MASH versus other diagnosis, the risk was higher. Male versus female gender, higher age, and again, immunosuppression. All suppressive agents are associated with increased risk of malignancies. But the most important one, again, is tacrolimus. The most important culprit, again, is tacrolimus. Again, this is a case control study of cancer patients who developed cancer post-transplant versus the controls who did not develop post-transplant. And then they divided the patients into those who were exposed to higher doses of tacrolimus initially and then maintenance dose versus conventional exposure versus minimized exposure versus aggressively minimized exposure when you give very low doses of tacrolimus initially. And then they compared the relative risk of developing de novo malignancies. And as you can see that over 3 months, also the cumulative exposure to tacrolimus, as it increased, the red one, orange one, green one, yellow one, and green, as it increased, the relative risk of developing cancer increased even up to 12 months. So as the dose of tacrolimus, again, like it was the culprit in renal failure, it is also the culprit in de novo malignancies. So the physician should minimize the doses of tacrolimus in consultation with hepatologist and manage risk factors aggressively. Again, we come to the same risk factor, that is MASH, and I'll again come to it in the end. Third most important killer is the post-liver transplant infections. So if you look at this particular graph, you can see that infection is among the very common factors which lead to probability of death in patients in the post-transplant period, like I said, along with malignancy and cardiovascular and renal factors. So how do these post-transplant infections evolve? When do they evolve? When do they come up? If you look at the timeline or months after transplant, usually the conventional nosocomial infections occur in the first month, like bacterial infections and fungal infection or bacterial or fungal sepsis. The CMV reactivation or infection usually occurs after 4 weeks, unless the patient has been given very strong immunosuppression. And the reactivation of hepatitis B and C infection causing liver injury also usually starts early in the first month and is continued throughout the next 6 months. And importantly, the other infections like important infections specifically in our country, like tuberculosis, usually happens in the first month, beyond the first month, and the risk continues for a long period of time till the time the immunosuppression is tapered down to a minimum level. Even after that, there is an increased risk of tuberculosis. And once the patient crosses the 6 months to 1 year period, because by that time the immunosuppression has been tapered to minimal doses, by that time the patient becomes prone to any other community acquired or persistent infections which may persist. And of course, they might be difficult to control because patient has been exposed to so many antibiotics in the past. So I'll spend some time again talking about post-transplant TB, because these are the patients, if they develop tuberculosis, they will be referred to a physician for their opinion. So the physicians must be aware of this. So usually the route of infection in the post-transplant period is most commonly is the reactivation of latent TB, followed by de novo infection, followed by donor-derived infection, which is less than 5%. So you take a liver from a donor and donor already has, say, a granuloma, a tubercular granuloma, which gets reactivated in the post-transplant period because of immunosuppression. So this was a meta-analysis of more than 2,000 solid organ transplant, of which 253 were liver. The median incidence rate of TB in the post-transplant period was 2.3%. But most importantly, or more importantly, many of them have extrapulmonary TB or disseminated TB, and it is associated with a high all-cause mortality of almost 18%. So I already talked about it. I'll just mention this small study from South India of because the data is very, very limited. This is one study of 214 recipients, 5 of whom developed TB, which was about 2.3% incidence after a median of 72 days. And the presence of unexplained granulomas in the explant liver, I just told you about it, appeared to be the only risk factor compared with match liver transplant recipients who did not develop TB. And again, the mortality was very high. Now, what are the issues when a post-transplant recipient develops tuberculosis? So one of the issue is drug interactions. As such, in a liver patient, you are scared of using these hepatotoxic anti-tubercular agents, and that fear continues in the post-transplant period. Once they are on ATT, if they develop liver LFT derangement, it is very difficult, or again, the challenge is to differentiate drug-induced liver injury or ATT-induced hepatitis by other causes of early allograft dysfunction, as I told you earlier, and the management of patients with TB in the extrahepatic sites. The important drug interaction which one need to consider and must know about is specifically rifampicin. It is a potent inducer of cytochrome P453A4, which leads to a significant reduction in their tacrolimus, everolimus levels, for which the doses of tacrolimus have to be increased 3 to 5-fold. Otherwise, the patient will develop rejection. So this is a problem while using rifampicin in the post-transplant period. So some people prefer using rifabutin, which leads to a lower reduction in tacrolimus because it is a less potent inducer of CYP3A4. And it has been shown in non-transplant setting that even if you replace rifampicin with rifabutin, the bacterial conversion rates are almost similar. So this is something which can be done, but unfortunately, it is not. This particular drug is not available in Indian market as of now. Very difficult to get your hands on it. So patients are being treated with standard regimen with either rifampicin or INH removed. So again, small data, like you see, these are two studies, 9 patients transplanted with active TB, 4 had ATT-induced ALF earlier. So they were treated with modified ATT. None of them received pyrazinamide. All 9 successfully completed the course and were free of TB for a median up to a median of 928 days follow-up. Another small study, 26 patients from literature, pulmonary TB 69%, nodal 11%. ATT was given with either avoiding rifampicin or INH, and it was seen that graft failure was more common when rifampicin was added to the regimen, and mortality rate was as high as 15%. So it is a problem in the post-transplant period, specifically early. If these patients develop TB, they have to be closely monitored with the LFTs, and they have to be treated in conjunction with a hepatologist and a physician. So the physician should remember that liver transplant patients are predisposed to TB that can occur anytime in post-transplant period associated with high mortality. They should use modified ATT again in consultation with a hepatologist. Keep in mind the drug interactions, and liver dysfunction while treating TB may not just mean ATT-induced hepatitis. You have to look for other causes also. Now, finally, we've been talking about the metabolic syndrome or metabolic dysfunction associated steatotic liver disease. And this seems to be the driver of all previous complications which I have mentioned earlier, and we must spend some time here. So it is divided into either recurrent MASLD if the transplant was done initially for MASH-related cirrhosis, or de novo MASLD when it was done for other indications. So this is a data from a French retrospective cohort study of 150 patients who had at least one graft biopsy 6 months after transplant, median follow-up of 4.7 years. And look at this, metabolic syndrome developing in 86% patients, steatosis developing in 85%, NASH developing in 60%, and significant fibrosis 48%. So that means almost 50% patients over time, so this is 10 years time, will develop advanced fibrosis because of MASLD, because liver transplant cures the cirrhosis but not the metabolic risk factors, which definitely have to be taken care for, and physicians have a major role to play there. So then they look at the presence of these metabolic risk factors, metabolic syndrome before transplant, long-term cyclosporin, because the CNI inhibitors is also one of the risk factors for developing diabetes, metabolic syndrome, and grade 2 fatty liver at 1 year post-transplant. So if you had any of these risk factors, your risk of developing advanced fibrosis was significantly higher than if you had none of these risk factors post-transplant. Again, this particular study looked at all the risk factors on multivariate analysis for developing de novo MASLD, obesity, tacrolimus, diabetes, hyperlipidemia, hypertension, alcoholic cirrhosis, pre-transplant MASLD, and they found that as the number of risk factors increase, so did the risk of developing de novo MASLD. So all these risk factors have to be taken care of starting pre-transplant and moving period. So I'll skip this because of lack of time. Just I want to highlight the fact that once you develop MASLD in the post-transplant period, the progression is rapid. This is what happens when you develop MASLD in general population, non-transplant. It takes about 30 to 40 years to progress from non-MASLD to a stage where patient develops cirrhosis. If you have a transplant done for non-MASH cirrhosis, this time period is telescoped to even a decade earlier. And if the transplant has been done for MASH cirrhosis, then this outcome happens in next 5 to 10 years. So you transplant a patient for MASH cirrhosis, and after 10 years, it is a high likelihood that patient will again have MASH cirrhosis, again highlighting the role of physicians managing the metabolic syndrome. So this is what it has been proposed, that even before the patient develop mast cell, that is, you must start 3 to 9 months after transplant, whatever intervention you want to do in order to prevent them for developing mast cell. Once they develop mast cell, then it is called secondary prevention. Then you have to start treating it. So how do you treat it? What about lifestyle therapy? We know that even in pre-transplant period, lifestyle therapy has failed. So it has even in the post-transplant recipients. So this was a office-based weight loss counseling which was done in liver transplant patients, and it was seen that the primary outcome of 5% weight loss was achieved only in 11% patients. If you just tell them, please lose weight, counsel them, only 11% of them will have some benefit. And if the NASH was the etiology in the first place, it was in fact associated with paradoxical weight gain rather than weight loss. So what you need to do is an active lifestyle therapy. This was a study comparing active lifestyle therapy in post-transplant patient, exercise of 30 minutes, 3 times per week with caloric restriction to maintain ideal body weight versus the usual care and counseling in 86 patients. And you can see that the body fat significantly reduced in the group which was given active lifestyle therapy with exercise and dietary therapy. But again, only 37% adhered to the intervention. What about bariatric surgery? Can we do bariatric surgery along with liver transplant? Yes, this was a study of patients who had BMI at pre-transplant of more than 35. Those who were not able to achieve a weight loss to a BMI of less than 35 were given liver transplant plus gastric sleeve resection versus liver transplant alone. And after a follow-up of 3 years, you can see in the group which received bariatric surgery along with transplant, they achieved a significant weight loss versus those who who were given only liver transplant. And yes, there was a significant reduced incidence of hypertension, hepatic steatosis, and insulin resistance, signifying that the metabolic parameters, metabolic syndrome also improved. So I'll just skip this and come directly to this because this is the new kid on the block. Everyone is talking about GLP-1 RAs, helping in reducing weight, controlling diabetes, controlling the metabolic risk factors, controlling the metabolic syndrome. How about its use in the post-liver transplant patients? So this was a study of 68 patients of OLT who were given either semaglutide, liraglutide, or dulaglutide for control of their diabetes, and they were followed up for 18 months. And you can see there was a significant improvement in their hemoglobin A1C. The BMI also reduced, and they found that it was safe. There was no increase in risk of the incidence of pancreatitis in the post-liver transplant period because of GLP-1 RAs. But can they improve survival? Now look at this. This was a recent study in 2026, a propensity matched analysis of 541 GLP-1 RA users versus GLP-1 RA non-users in the post-liver transplant period. Look at this. All-cause mortality significantly higher, all-cause survival significantly higher in patients who were given GLP-1 RAs. All-cause hospitalization also significantly better if they were given GLP-1 RAs. Acute heart failure events significantly better with GLP-1 RAs. Acute renal failure significantly better with GLP-1 RAs, suggesting that all the risk factors, all the reasons I told you previously about the reasons for dying in the post-transplant period were taken care of by GLP-1 RAs, and there was no increased risk of rejection. But yes, we need to have more data before we say that this is going to become the standard of care. Another important thing which must be kept in mind that once these patients have metabolic syndrome, you have to have different strategies in terms of managing their immunosuppression. For patients who have diabetes, steroids should be tapered off and stopped early. TAC might be converted to cyclosporin because the risk of diabetes with TAC is higher. If you have hypertension, you want to minimize steroids in CNIs. If you have hyperlipidemia, you want to discontinue mTOR inhibitors early. Again, you still have to keep in mind drug interactions because these patients receive a lot of drug, especially in the initial post-op period, and they continue to receive immunosuppression later. So drug interactions have to be kept in mind. So these are the drugs which usually increase the TAC levels, and the clinically relevant interaction happens with antifungals, that is fluconazole and voriconazole, especially in the early post-transplant period when these antifungals are given for prophylaxis. And there are drugs which reduce TAC levels, and I did talk about rifampicin and rifabutin when you start treating these patients for tuberculosis. With that, I come to the take-home messages. During long-term follow-up of liver transplant recipients with stable liver function, the 4 most important killers are infections, cardiovascular problems, cancers, and CKD. The most important drivers of most of these problems are 2: tacrolimus and post-transplant metabolic syndrome. And since we are talking about post-transplant metabolic syndrome and MASLD, physicians have a very important role in controlling, preventing, and treating this metabolic syndrome, as well as its downstream effects. And there, I think GLP-1 receptor agonists, semaglutide, tirzepatide, and the ones which are yet to come or become available in the market, they definitely hold a promise even in the post-liver transplant population. Thank you for a patient hearing.
Thank you, Kaushal. That was a wonderful overview of how actually what we do at work in the post-transplant patients. Shall we have panel discussion now?
Yes, this is the time for panel discussion. I think we can begin with the moderators, Dr. LVK sir, followed by the other moderator, and then the other panelists, followed by the postgraduates.
Yes.
I think we should invite the other panelists also.
So may I invite Dr. Lamba from Action Institute, New Delhi, and Dr. Bidan Nidhi from Kathmandu.
I think Dr. Bidan is not seen. I think he could not join. Yeah.
And 2 postgraduates, Karthik's.
Yeah, Karthikeyan and Karthikeyan S. Yeah. Dr. LVK sir wanted to start with a question after the first lecture. Can you start, sir, please?
Yeah, I was asking Dr. Joy, sometimes when we are working for pre-LT, how often you need to do coronary angiogram in all the patients, or should be limited after doing a perfusion study? Because occasionally what we have found in our place is that post-transplant, a completely normal cardiac status before that. We have not done coronary angio, but we have done only a stress test and or myocardial perfusion normal. But they do land up in stress cardiomyopathy. They get into fluid overload state, they become tachycardic, there's no infection. So how do you predict this, and how do we evaluate this sort of people? In the last week, we had a transplant on the 48 hours later, he was breathless and there was EF has fallen down, something like a stress cardiomyopathy. So how do we predict this? This is something which, can we predict this pre-operatively when these patients can go for us? Okay.
Thank you, sir. So actually here over the period of time, so how we are doing the cardiac assessment in a patient waiting for liver transplant. If the patient has, number 1, age more than 50, they will go ahead for the coronary angiogram. So it's no recommendation. If you look into the worldwide, there's no recommendation. But we are seeing more and more people have the cardiac issues. And either they will have the current diagnostic angio will show 20% block, 30%, but we are not going for intervention, but that is the basis required. And if the patient has the associated comorbidity like a diabetes, hypertension, and obesity, morbid obesity, and smoker, these all the groups, irrespective of the age, even though a patient has 45 years, they have the diabetes for more than 10 years, or hypertension, or chronic smoker. So these are. So normally in our center, we used to take, whenever we are taking the CT abdomen, we cover the chest also for the calcium score, coronary calcium score. the coronary calcium score comes whichever the patient more than 100. Normally, calcium score should be 0. Or maximum we can count less than 10. Those who are more than 100 coronary calcium score, they are more to get this kind of the block. And the intervention, whether to intervene or not, everything is a cardiologist, suppose as per the recommendation, cardiologists, the society association, where they will look into the collaterals, etc., they will decide. But age more than 50 and a smoker or diabetic or the chronic hypertension, long history of hypertension or dyslipidemia, obesity, these all will go for diagnostic coronary angiogram as a part of pre-liver transplant evaluation.
One more question is the hypothetical situation where somebody is listed for a transplant and he interveningly develops HRS AKI and say he is recovering. And somewhere around the creatinine is 2 or 2.2 and we get a liver. Okay. He's not dialyzed. Urine output is okay. He's not acidotic, but we say creatinine is 2.2. So we get a liver. So at least what is the knowledge we have? Sometimes I feel that we can go ahead and do a liver transplant, but there may be 75% chance the kidney may recover after transplant. But there's 25% chance that the kidneys may worsen after transplant. Sometimes when the liver comes, sometimes the transplant surgeons are very, very scared to do the transplant when the creatinine is 2.2. So do we have any data to say or any guidance to say that if this sort of creatinine of 2.2, 2.4, we can safely go ahead and do a liver transplant and wait for the kidney to recover? Because sometimes the transplant surgeons are not keen to do when your creatinine is elevated. Can you throw some light on that?
Yeah. The guidelines are there when to do combined liver and kidney transplant. When to do. Suppose the patient already on dialysis or the CKD more than, the GFR is less than 30. But if it's fulfilled, fine. But as you said, it's not fulfill the criteria for combined liver and kidney transplant.
Yeah.
Because creatinine is elevated at the same time, not oliguric, not depend on any dialysis. Urine output is good. So this will come into the criteria of the AKD. That's why the slide I mentioned, acute kidney disease. This acute kidney disease, what we have to do that, we shouldn't recommend for combined liver and kidney, number one. We should go ahead for the liver transplant alone. At the same time, which are the factors will worsen the renal function, we know. Number one, prolonged intraoperative time, massive blood transfusion, inotropes requirement, post-op sepsis or post-op immunosuppression. So as a team level, we have to be predict, okay, this criteria, these are the things, whichever thing mostly avoidable and maintaining the CNI. So this kind of the way we can avoid that further deterioration of the renal function. Some of the patients after liver transplant, the renal parameter will show some improvement. But if you take the so whenever they are coming for follow-up, because we have a data of patient on day of surgery, those who have the renal dysfunction, you know to say like AKI or AKD, outcome overall, long-term outcome is not good. And
especially if they are diabetic and people on mast cell who we do transplant, they have a very high chance of developing, when they have this borderline creatinine, we do a transplant, then they may go on to a CKD later.
Yes.
Sometimes it's very difficult to explain to the patient. And two things, some patients don't want to take the risk. And second thing is the surgeons also are sometimes very wary because most surgeons don't like perioperative or a post-operative dialysis transplant.
That all we should be, might require the CRRT support intraoperatively. These all we will explain, but go ahead for the liver transplant at present because not a fulfill the criteria for combined. At the same time, there is no data to say evidence are there. Okay, we shouldn't do also.
Dr. Joy, if I may ask one question.
Yeah, please.
Yeah. One very common problem with these patients, and which also forms a sort of indication for doing the transplant, is sarcopenia. Now, once where you were talking about optimization of the patient, that was a topic. So should we really waste our time in improving sarcopenia? Why I'm saying from a practical point of view, sarcopenia is something which will not improve in a week or maybe a month's time. So, and it is very, very difficult practically to improve sarcopenia to feed these patients. And sarcopenia itself is an indication for them to go for transplant. So should we be wasting time in optimizing these patients, or we send them for transplant? Probably that will improve their sarcopenia.
So in the living LDLT setting, living donor, what we are practicing most of the centers. Yeah, so mostly we will not wait, like what you said, the optimization is not possible, because meanwhile they will get other problems and other things. So we have to assess the sarcopenic individual, are they really fit candidate for liver transplant or not? Like a 6 minutes walk test. This all some of the tests by doing, if the patient is fit, we have to go ahead. Sarcopenic individual, even not able to do the 6 minutes walk test. So that time, if you are going to take the case for liver transplant, the outcome will be bad. So we have to keep some of the tool, the sarcopenic groups in the LDLT setting when not to do transplant also. And the thing, and they are not able to do the spirometry, even though they are not able to lift even one single ball. Only so that all we have to keep in mind that groups after transplant will be on ventilator dependent. And everything is difficult. But the DDLT setting, okay, we have a time period, but most of the time it's a real challenge. It's not like it, because most of them are child disease status, nutrition, whatever we are giving supplement.
It doesn't help.
Not, but the physiotherapy also, some sort of physiotherapy, they can do it. But optimally, okay, but we know when not to do transplant in sarcopenic groups, like 6 minutes walk test or spirometric, they are not able to do. That's why we are looking.
Pre-operative, I think tips may sometimes, when we are doing for a refractory ascites also, the only intervention which could improve will be a tips, not for sarcopenia, but when you do for a refractory ascites, maybe they also improve on the muscle mass actually. That is that intervention made. But there's no definite indication of doing tips for sarcopenia. When you do it for refractory ascites, then they also improve.
So you asked about the question on the stress cardiomyopathy.
Yeah.
So with regards to, there are two things. One, coronary artery disease. Other is cardiomyopathy. Two are different. To screen,
so these patients are pre-operatively have been cleared as a normal E of everything.
So we need to look at underlying cirrhotic cardiomyopathy, which many times we don't actually look at. So these are the patients who will have normal ejection fraction, but diastolic
dysfunction.
So these are the patients, if they have any added risk in the perioperative period, like a prolonged surgery, multiple transfusion, they are prone for stress cardiomyopathy. So as a hepatologist, when you assess patients for transplantation, it's very important to know whether this patient has the LV diastolic dysfunction. There are set criteria for cirrhotic cardiomyopathy, particularly more common in patients with alcohol, and we are seeing patients with mast cell as well. So we need to address this, and obviously for cirrhotic cardiomyopathy, transplant is the treatment. But we need to be very careful in the perioperative period, to address that particular issue.
Generally, they settle down, and this patient develops within 48 hours. The only worry for us is the tachycardia is very persistent sometimes. Then you are in a fix whether this is because of heart or he is developing a smoldering infection or something.
So cardiac arrhythmias developing in the post-operative period is predominantly because of underlying cirrhotic cardiomyopathy. So that factor should have been taken into consideration in the preoperative echo. What happens is many patients are on diuretics, so you may not actually see the full-blown cardiomyopathy in these patients. So we have to be very careful in assessing these patients for transplant.
And sometimes I think if you are a little more aggressive with the albumin post-operative, also it can push through to the thing. And I feel that if your drain is not big enough, I don't think we can really come down on giving post-transplant albumin infusion. Your drain is not very high. It's not more than 500 ml or liter.
That's right.
Can I ask a question to Dr. Joy, sir?
Yeah, please.
Sir, what this from the audience? What measures should the caregiver adopt for a patient plan for a transplantation? What is his role, the caregiver as a caregiver?
Caregiver means family members?
Yeah, family members and the relatives of the patient.
Waiting for transplant or?
Waiting for transplantation.
See, the waiting for transplant, the caregiver role mostly, I mean, nowadays, the diet and the physiotherapy level, so they have to, I mean, in our center, that's practicing. We will educate them. Okay, and that way the counseling is important. Okay, because they have to understand what type of diet and how often do the routine thing only, but we have to spend some more time. We can't send doctors, so we can appoint some people. They have to keep on educate. And the same way, some physiotherapy. Physiotherapy, very simple exercise. Particularly here, we are keep on insisting for the spirometry. The spirometry is doing wonder. Suppose a patient waiting for suppose we are any patient and they're waiting for transplant, they are regularly, here we will say every hour, 10 times, they have to lift the balls. Okay, there is a, if you suck there are 3 chambers, we know the balls will be there. So there is a inspiration and expiration and the blow. So minimum 2 balls, they are able to lift it up, that 10 times in an hour, except the sleeping hours. That's a routine practice. Second thing, nowadays we are giving more and more oral hygiene. So all the patients, we are telling the mouthwash, actually even night time, before going to bed, either they have to use the routine, whatever the way mouthwash, or until it's the chlorhexidine, that kind of the way, so mouthwash. The oral hygiene maintenance and the spirometry work, that all, it's reducing the post-operatively, the complications to the patients.
I think any cirrhotic patient should be taught by the physiotherapist to do the simple walking, chair exercise, and build your muscle by using this biometric exercises. I think we should teach to every cirrhotic so that it prevents sarcopenia. And when there's sarcopenia, as Joy said, we have to do this. You should get the physiotherapy in your team and then start doing it.
One of the problems with the carer is they inadvertently or knowingly give more salt in the diet. And that should be re-emphasized every time they come to the outpatients, you know, because some patients, they come with suddenly with more ascites, and you know, the family member would have given more salt in the diet, or they would have gone out somewhere and had outside food. So these all should be restricted, actually.
Okay, thank you, sir. Can we ask the postgraduates to participate and ask questions to the speakers? Dr. Karthikeyan, yeah.
Good evening, sir. CLD patient have some immunosuppressant loss of immunity. Patient have lot of sepsis, like you mentioned about some dental sepsis, and a patient also have latent tuberculosis like that. How aggressively we have to screen and treat before transplantation?
This is a question for Dr. Joy, sir. Kaushal.
So I think I agree, although the Western guidelines say that latent TB should be looked for, but that's not the usual practice in our setup, at least prior to transplant. And it has been shown that it does not help in prevention of post-transplant TB. So there have been studies which suggest that one, the test may not be reliable, and second, it may not prevent the number of TB infection in the post-transplant setup. So in most of our centers, in fact, I had a presentation on this a few months back, and there was a lot of discussion. And I think none of these centers in India is using this policy. Dinesh, Dinesh and Joy, what policy do you follow in your setup?
So we screen patients annually. We do annual health check for dental procedures if they need, or ENT checks like that. And we send them to the dentist, and if they require any dental procedures, we jointly manage them. So that's where physicians' roles are very, very important in the long-term follow-up of, as you mentioned, it's not the liver that's causing the problem. It can be other organs. So therefore, it is very important to work together with the treating physicians to address this particularly dental issues. What was the other question?
The issue of screening for latent TB.
So we don't actively screen, actually, because most of us are exposed to TB at some point. So we don't generally actively screen. But at the time of transplantation or pre-op evaluation, if there are any nodes that require sampling, we do that, and then we keep it in mind. If anything props up in the post-transplant phase, then we'll address that. We don't routinely keep actively searching for TB.
Right.
The problem of the thing about this screening for latent tuberculosis, even they are negative, but during the waiting period, if they've been exposed to some patient with tuberculosis, they can always still get infection post-operative.
Right. So I think Dinesh said, I think it's better, even if it comes positive, it's better to wait for the TB in the post-transplant period and then treat them rather than delaying the transplant, unnecessarily running after latent TB. I think that's the policy which is being followed in most centers.
Yeah.
Dr. Karthikeyan A, do you have any questions to the speakers?
Yes, sir. My question is to Joy, sir. I want to know what are the vaccination we can recommend for a pre-transplant patient. If there is any changes in vaccination for the people who are already in immunosuppressants.
So normally the vaccination ways, we have to give the DPT, number 1.
Okay, sir.
Second, hepatitis B. Third, pneumococcal vaccine. The fourth is the flu also. Okay, this normally all the patients waiting for liver transplant, they have to get it. So already immunosuppressor means suppose if there are, do you mean the associated HIV infection or?
No, sir. If patient already taking azathioprine for autoimmune hepatitis or on steroids.
There is no change in the vaccination protocol. If the patients are going to take azathioprine or the tablet-based one, see, if you look into the most of the decompensated chronic liver disease patient, once the autoimmune related, so continuing the azathioprine or the Weisswurm is not advisable. Okay. So not recommended. If the patient have the suppose associated HIV infection, that time also the policy for the therapy is the same only. There's no change.
Okay.
Sir, when the patient is already taking immunosuppressants, for example, steroids or Azuran, live vaccines are not to be given. So what kind of hepatitis A vaccine, do you recommend actually the hepatitis A vaccine in such patients? Because we don't have the live hepatitis A vaccine for the adult dose available in India. So the Havrix, the other one, which is BioVac, is the live vaccine. So how do you actually deal with this condition?
So normally, and sorry, I missed one vaccine called varicella zoster. This also we have to give. There is 2 types of varicella, so killed. So normally, as you correctly pointed out, all the vaccine, whatever we are going to give the killed. Suppose if you are going to the live vaccine, we shouldn't do the transplant for minimum 1 month. we have to wait, okay? Because if you are going to do transplant, after transplant, we are subjecting the patient into suppressive drugs and other things. This was the discussion wise, our ID earlier used to wait for 3 months. So then what I said to them, so our patient waiting for transplant, getting one live vaccine, they can't wait for 3 months. Better not to give vaccine. We will go ahead for transplant. After that, we will plan. So that kind of the way discussion came. So normally the live vaccine better to avoid for the decompensated chronic waiting for. If the DDLT deceased donor, the waiting list is suppose not immediately 5, 6, they take a more time in. That time, please go ahead for the live vaccine. Otherwise, not recommended.
For the varicella, we can sometimes check the VZV antibodies. If it's a very high, you can even do the transplant and then take it forward.
So, Joy, when is transplant too late?
Yeah, too late. Normally, that's it. Just we have to see the just a simple way performance status. If our patient we are seeing OPD almost, if they are coming with a stretcher, so we shouldn't subject the case. We shouldn't talk about. No need to talk about liver transplant because such a patient, even though they are not sarcopenic, bedridden like a status. Okay, simply we can say it's a too late. Okay. Otherwise, we have to see that any active infection is there means we shouldn't do the transplant. And too late means mostly I'm seeing sarcopenia and they'll become a wheelchair bound. Even they are not able to get up. They can't be, even with the support, they are not able to get a few steps. Always they need the nursing care, bed care, everything. That time it's too late. We're going for transplant.
So very poor performance status, and particularly in ACLF, we see very sick patient, more than 3 organ failures. So those are the patients who should not transplant.
I had a situation where the patient is blind and he cannot help himself much, but he's got cirrhosis. He is not well compensated. The family asked, should we transplant him?
We've done transplant for somebody with retinitis pigmentosa with other disease, and they're doing very well actually. So
yeah, they
somebody
do very well, but
blind,
and I think if he has got enough social support, I think we should.
Kaushal, what is the myth of liver transplant? There's a lot of non-transplant clinicians watching this. What is the myth? Why people in the community, do you think they are just not aware of transplantation?
I think many people come to us, and once we break them this news of the fact that they will require transplant, many family members, they say, oh, but there is no life after that also. So many people die and they have to take so many medicines lifelong. The treatment is as expensive as it was prior to transplant. And I think, like Joy also mentioned, and the data I showed, I think the society needs to be made aware of the fact that more than 90% patients are able to walk out of the hospital after transplant. And even after that, more than 80% will have a long-term survival. And when we say long-term survival, means it's beyond 5 to 10 years. Many a times when I talk to the relatives about, say, 5-year survival, so they ask me, oh, does that mean he'll survive only till 5 years?
5 years.
So I tell them, no, once he's beyond 5 years, it's like a normal lifespan. So that is the kind of counseling they need. And yes, the physicians also should be aware of the fact that you get a very good survival. Gone are those days, say about 15 years or say 2 decades back, when the survival was not that much. But over the last 2 decades, the immunosuppression protocols, the post-transplant ICU care, post-transplant management of complications have improved tremendously. So that is the thing. And regarding lifetime medications, I think ultimately you are left with only one immunosuppressive drugs and few adjuvant therapies which are required. So I think ultimately after a couple of years, everything comes down. And even there are reports, there are series, and there is experience. I'm sure you also are experienced that even ladies, young ladies who have been transplanted can become pregnant later on and can deliver healthy babies. So once you are beyond a certain time, you live a almost normal life with some precautions.
That's excellent, actually. Yeah.
This Dr. Kaushal, this combination of PAC and sirolimus, everolimus, you have put it across. When do you start everolimus? Do you really start upfront, or you need to wait for about 2 weeks or 4 weeks before you switch on to everolimus?
I think that's a very important question, because it is usually thought that mTOR inhibitors reduce or slow down the healing, the post-operative healing, wound healing. So it is recommended that usually be started after 3 to 4 weeks of transplant. And once that is started, then you can reduce the tacrolimus dose. So only in patients who are at high risk of developing renal failure or who had mild CKD to begin with are the ones in whom this can be tried. Other centers may use basiliximab induction, whereas in our center we don't use that. We prefer reducing the dose of tacrolimus rather than induction.
Postponing the starting with the basiliximab.
Yeah. Postponing, even if you have to add everolimus, it should be postponed to about 3 to 4 weeks.
Because generally the recommendation is after 2 weeks, because the healing has to happen.
Right. Minimum 2 weeks, yes.
I think Gokul,
Yes, sir.
do you agree with me that we had a wonderful speakers and panel and question?
Yeah,
So
definitely.
we have only 8 minutes to go. So you want to have the chit chat session a little lighter for the audience purpose, okay?
Yes, sir.
So what is your first question? First question to you I am going to ask. How do you do the work-life balance?
To me, sir.
Yeah.
So I generally
Because-
compartmentalize. So as long as I'm in the hospital, I do all the work. I try to complete all the work in the hospital itself. And once I go home, I generally don't bring any of the hospital things, discussions to my home, and fully concentrate on what I have to do at home.
So you will not attend the phone call from a hospital then?
That's an exception, sir. Definitely I will attend the phone.
Okay, right. I think we don't trouble them also, our consultant. I think I appreciate your answer. And Kausal, what is your work-life balance? Because people keep working long hours. You're there. I'm talking from airport, so please excuse me. Okay.
I think that's a very important question, I think, and I think everyone should be looking for that and working towards that. And yes, I agree when maybe a couple of decades back or even 10 years back, we would be working very, very hard, but I have made a deliberate effort to slow down. So possibly once in a week, second half of the day, I keep weekend, I don't have any appointments. I come back home early and spend time with the family. During the weekends, unfortunately, there are a lot of conferences these days. So you tend to travel in so many weekends. So again, you are away from family. So one thing to do is to take your family along. After you finish with your conference, say, stay for a couple of days more or go out somewhere from that particular destination to another destination and come back.
I think you are a good manager, Kaushal.
No,
And
but
Gokul is
still
a good compartmentalizer. And you are
the
a good
family is.
manager.
If,
Okay.
I,
Now
I
we
would
need
just
a very
family is
brief
not happy.
answer. Very brief answer. GS Lamba, what is
Yeah,
your
I just
work-life
want
balance?
to quote from Dr. When I was listening to Dr. Reddy's lecture of work-life balance, and he used a sentence that it's actually not work-life balance, it is work and wife balance. It should not be life, it should be wife. So there is no one answer for this. It is you have to make your own, balancing acts there.
So how
Because
do you balance? The question is to you only.
I don't even
How
know
you are
whether I have balanced
balancing?
or not. So it's very difficult to say whether it's balanced or not.
Okay. Right. LVK, you also work long hours. What is your work-wife balance or work-home balance or work-life balance?
Just finish all the work and go home, and then once you finish all the work and settle everything, I'm at peace. So I just go and
So
just
you
relax.
want to complete the work so that you don't want
And
to carry.
whenever I travel as Kaushal says, take the family or take your wife. And
So
that's the
taking
time
the family when you are attending the
wife needs
conference,
to be covered
number
there.
one, compartmentalize. And Lamba says work-wife balance
And
rather than
catch the
work-life.
sleep on Sunday afternoon between 2 and 6 p.m.
2 and 6 p.m. luxury. LVK?
2 to
Very
6
good,
p.m.
very
on a
good.
Sunday afternoon.
Sunday afternoon. Okay, that's a very good. Actually, most of the gastroenterologists started having a little more than nap on Sunday. What about you, Dr. Dinesh? Your work balance?
So morning, I give time for myself in the morning, and
You are a
in the
marathon runner, no?
I do run and exercise. So I like to do my own things in the morning and
Yeah.
start the day early morning, little slow actually. Okay,
What
and
time you start? 6
five,
a.m.
five, five.
5. And you go for walking.
Yeah, walking, whichever, running, swimming, or gym, something or the other. I do it for an hour, hour and a half. That gives a lot of clarity to the day. That's how my day starts.
Oh. And joy, what is your, how you are so joyful?
Sir, everything is about our mindset. Suppose one time, okay, at the same time, everyone has their own passion. Okay. So I love to listen music and watching movies, and mostly at home itself, the gym and the kind of exercise. And I like that meditation, even though suppose if you are going to do a few minutes, that is giving mentally very, we feel much relaxation. Just
So you have multiple ways of relaxation. So you are an exception. And Dr. Dinesh is the morning hours is time. No one should disturb him for 2 hours. And Lamba says he is more concerned with the wife and comparing to the other thing. Okay. What about the postgraduate? That also they have the tough time. What is your work life balance postgraduates? Karthik
Sir,
and Karthik.
usually we have Sundays off.
Seminars.
Sundays.
Okay. Okay.
Sundays I can spend with my family, wife.
Oh, okay, right. Then that is the nature, I mean, regular way of doing it. Another Karthik,
Sir,
he has not
evening.
balanced himself or is balancing?
No, sir, I am not married. So,
Balanced.
That's why you're looking very happy, Karthik.
not like
Very happy you're looking. No, don't think other way. Everyone is can. All you said. I think I like the sentence, the mindset, how you are organizing yourself, the time management, and tell your spouse very clearly what kind of work you are doing it, and you involve them also some of the empathy and sympathy you are having. Then the wife also started having empathy on you, sympathizing on you, so they will not make a big fuss about it. Now, other question is, who is your hero in life? Dinesh, will start from Dinesh. One word answer now. We have only 2, 3 questions.
So for me, it's Professor Rela.
Rela is your, and Dr. Kausal, who is your hero in life?
So I think professionally speaking, Professor Acharya, and apart from that, there's so many heroes. There cannot be one hero. You draw inspiration for from so many people.
It's
From
hero, not hero.
Maybe you can tell 1 or 2 more. So many heroes you are telling.
No. So I said professionally speaking, Professor Acharya,
And
and
Cinefield, who is your hero?
is Cinefield.
Hmm.
Heroines.
That's
Question.
so difficult question.
Okay, when you are pondering,
I
he
usually don't
confused you
form.
with the hero and heroine. So that's why you confused.
So I usually don't give that status of hero to people very easily.
Very easily. Okay. So I have to work very hard for that then. Okay, right. The Lamba, who is your hero in life?
So professionally speaking, Professor Serene, and in films, it's Amitabh Bachchan.
Okay, very clear cut answer now. LVK, who is your hero? He'll be very shy even if you ask about hero also. LVK?
It's very difficult. There are so many people who have shaped your life, actually. But I
No,
think
we ask only difficult question here.
Because there were quite a few mentors who mentored us. And so, initial part, you were also in Coimbatore and you also were one of our mentors.
Now, after that, I withered out. Huh? Yeah, okay.
Who
I
inspired
think,
the case of gastroenterology was Philip Augustine. So,
okay, right. Then, Joy, who is your hero?
Professionally, Professor S.K. Sari as well as Nageshwara sir. But I will see some people with amazing way, I mean, particularly Ilayaraja. So I really amazed about his knowledge. So some of the people much impressed.
And Gokul, who is your hero?
Sir, movie-wise, Kamala Hassan, and professionally, it is you, sir.
Thank you. You made my day at least. I did not tutor Gokul to tell this. So, okay. Okay. And postgraduate, who are your heroes? Quick.
It's
Okay.
difficult.
No, difficult means you have to answer then.
Okay.
In the Viva, you can't say like that.
Yes, sir.
Then the result will be difficult.
Mm.
Okay. What is your unfulfilled dream which you want to aim at? Gokul?
Maybe publications, sir, which I'm lacking. I should work on it, sir.
Okay, I'm glad that you said that, and then we'll start working on that. Joy, what is your unfulfilled dream?
Is to become a big businessman.
What's that? What's
Businessman.
that?
Wish to become a good businessman.
Businessman.
Businessman. Okay. Kaushal, what is your unfulfilled dream so far and you are aiming at?
No, I'm not aiming at it now, but unfulfilled is to be involved in music, either playing an instrument or to be able to sing well. So
Okay.
that is unfulfilled.
Okay, music. LVK, what is your unfulfilled dream which you would like to pursue?
I think I should wish I had more time, like Dr. Kaushal said, to listen to Carnatic music because I love that.
Oh, Carnatic music.
But
Okay.
still, late in the night, I put on MS Subbulakshmi and
Oh, fantastic.
listen to her.
You understand Carnatic music?
Yes. Because when I was in Andhra Pradesh, my father used to be one of the members of.
You can identify the ragas?
Not much, not many, but something. But
Okay.
you had the heart.
Dinesh,
So I can enjoy the Carnatic.
okay, Carnatic. Dinesh, what is your unfulfilled desire?
So for me, I have to complete my Western classical degrees, music.
Oh my God, you are a marathon runner, swimmer, and transplant hepatologist, and Western musician. Okay, I think we had a very fantastic time. Gokul moderated very well in my absence for 1 hour. So I had to catch a flight, so I am in the airport. And both the speakers did a fantastic job. I think they made a very good carry home messages, and they moderated ably by LVK and Dinesh, and the speakers stuck to the time and the topic, and the postgraduate showed enthusiastically got involved, and we had over 500 delegates attending this webinar, and we look forward to you seeing you in the next webinar in June. Okay, thank you very much, and I convey this all the thing to American College of Gastroenterology for the successful webinar we had on liver transplantation, and thank you very much for this wonderful opportunity.
Thank you, sir.
Thank you, sir.
Thank you.